At this COMy meeting, I'll be discussing on the bispecific antibodies in multiple myeloma. So over the last, really the last couple of years, we have seen the emergence of this new class of immunotherapy. They consist on antibodies or with different types of construct, from being very small pieces of Fab tied together to entire antibody molecules tied together by their Fc ends that simultaneously bind to a target on the multiple myeloma cells and a target on an immunoeffector cell, typically T cells. On doing so, those antibodies have the property to recruit and retain those effector T cells into the tumor microenvironment, lead to activation of those T cells and degranulation, and eventually, tumor kill. So in a way, it delivers a similar mechanism of tumor destruction than we see with CAR T cell. At the end of the day, is a T cell that get engaged and directly kill tumor cell, but without some of the constraints that comes with CAR T cell, for the need to collect cells from the patient, manufacturing, modify genetically those T cells and reinsert on the patient. For being an off-shelf product, it also has the possibility of promptly starting therapy without that delay that comes with the manufacturing, making it, at least in theory, more attractive. Another potential advantage of the bispecific antibodies is the fact that even though they produce cytokine release syndrome, very much like in CAR T cells, the cytokine release syndrome limiting step here is the amount of antibody, as opposed to CAR T cells, where when we infuse the product, those cells expand and you don't have much control over that. So by implementing step-up dosing, where you use incremental doses in subsequent sessions of administration, at least in theory, you can have a greater control of the cytokine release syndrome. Clinical data is very premature. We have seen several phase 1 studies, all target with bispecific antibodies targeting BCMA. We have seen data for AMG 420 a couple years ago. Last year at ASH, I had a chance of presenting preliminary data on CC 93269. And more recently this year, we have become familiar with the data for Teclistamab. They all look very attractive, and I think it's really premature to try to distinct any major difference among those different bispecific antibodies. All those trials had a population of heavily pretreated patients, particularly with Teclistamab and CC 93269. The vast majority of patients were triple class refractory, and we saw response rates over 2/3, responses in over 2/3 of the patients at the at a higher doses that were tested. So that is certainly very encouraging and really sets a bright future for this class of immunotherapy. I'm very excited about the future. Not only are we going to see more data and more mature data for the BCMA bispecific antibodies, but there are several other bispecific antibodies in development targeting, for example, FcRH5 and GPRC5D, which are other very attractive immunotherapy targets in multiple myeloma. And we hope to see some of this data in the upcoming meetings. I think the data as it is leaves several opportunities and several open questions. I mean, one is What is going to be the long-term disease control? For being off-the-shelf product, you have the possibility of continuous dosing for a long period of time, which is another difference to CAR T cell. Is this amenable to combination therapy, and how will those agents perform when combined, for example, with with monoclonal antibodies or with immunomodulatory agents? What becomes the optimal sequence? Now we're seeing several different BCMA targeting agents, CAR T cell, bispecifics, antibody-drug conjugates. So does it really matter and how prior therapy with one of those agents would affect likelihood of response and toxicity to another class of agent? And one that is kind of harder, but perhaps the most intriguing question is certainly not one of, like any other myeloma therapy, this is not one that works on every patient. And even though BCMA is universally expressed, so will ever be able to predict what patients are more likely to respond. And that's going to be, would that be a function of the disease biology? Would that be a function of BCMA expression? Or more interesting, would that be a function of the health of their T cells? I think that's all the correlative data that we need to see in the months and years to come.